please welcome Maggie Breslin, co-director of the Patient Revolution.
Thank you. I'd like to start by saying thank you to all of the women that let me jump the line at the bathroom. It is a week for solidarity, so I appreciate that very much. The story that I'm going to tell you today is actually the story of my first project collaboration with a group known as the Knowledge and Evaluation Research Unit, which is a clinical and translational research group at the Mayo Clinic. Very much seeped in the idea of measurement and evaluation and how we talk about those things and how we publish about those things within medicine. And I'm going to tell you the story of this first collaboration, even though it was 12 years ago, and now 20, 25 projects later, and one spin-out nonprofit. I think that there's a lot of interesting seeds for what potentially creates an interesting collaboration between designers, which is what I am, and measurers and evaluators and researchers from that world, as well as maybe a place to think about what long-term collaborations between multidisciplinary teams might begin to look like. So the work that we did, this first project, was under the umbrella of what's called shared decision-making, which, like a lot in medicine, is a very academic and formal title for something that you pretty much thought was happening naturally. And the idea behind shared decision-making is it's a place for dialogue between patients and clinicians where benefits and trade-offs are discussed on issues where there are options or there's some sort of degree of uncertainty. And in particular, this world of shared decision-making has to some extent been defined by support of the use of a tool or an aid as a way to facilitate these types of dialogues. And it was partly for that reason that I think it was interesting and attractive to the idea of design and bringing a designer on board, because there was a thing to be made. And so this is just a little bit of a storyboard that gives you a sense. The tool that I'm going to talk about today was actually a decision tool for people with type 2 diabetes who were on one medication and were considering the addition of another medication to the regimen as a way to control their A1C levels. And this is a little bit of a snapshot of how the final tool that we created sort of worked in practice. And I'm going to play a couple of bits of a video so that you can see the very exciting world of what shared decision-making looks like in reality.
So yes, I agree. We need to make sure your sugars are better controlled. So that means we need a new medication. So which aspect of your next diabetes medication do you want to discuss first?
Weight change.
Weight change? I'll let you review that.
Okay. So this is the one that I'm on.
Yeah, you're already on metformin.
Well, this one looks good to me.
Yeah, that one is going to help you lose some weight.
Yeah.
What aspect of that medication would you like to learn about next?
I'd say the daily routine.
Sure.
Okay, so.
Yeah.
Oh, so this is an injectable.
Yeah, it's actually very easy. There are a couple of pens that have needles, and you inject the needle into your belly and do that twice a day before your meals.
Yeah, I don't think I really want.
You don't want to go needles?
No,
okay.
no.
So a little bit of a window, kind of how this exchange begins to happen. So when we started out on this project, I sort of was bringing to it, this is the very first project I worked on with this team, and one of my very first projects working on within healthcare. And so my nervousness was pretty high. And so we started out using the design approach and going out into the field and observing what these conversations between doctors and patients about their diabetes medication look like today. And this was sort of the model that we came up with. After 12 or 13 years now and hundreds of visits, I can tell you that this is pretty much the model for most conversations about most medications, which is at some point the doctor says, I think you need a medication. And then they write you a prescription for what that medication is, and they hand it to you. And then the patient takes that prescription home. And it's sometime outside of the clinical visit when the patient actually makes a decision about whether or not they're going to use that medication. They make a decision when they decide if they're going to fill it, when they decide if they're going to take it the way it was prescribed, when they make a decision about whether or not this is cost effective or actually going to bring some sort of value or meaning to their life. And so from these observations, what we did is we began to create a hypothesis. And we said, what if we could take all those factors and all of those ideas that the patient has in their head when they're making the decision by themselves and begin to get them to express those when they're in the room with the doctor. That way, the physician can pull from their own experience as well as from their medical knowledge to begin to share information that may be important for this patient to know if they're going to be participating more fully in the decision-making process. And so what I'm going to do quickly is, because I always really, so often when we tell design stories, it's such a linear, it was like, we had the project brief, and then we made this amazing thing. And of course, there's often lots of little steps in between where things didn't work and you went down cul-de-sacs that didn't prove to be very fruitful. So what I wanted to do is give you a little bit of a glimpse on this very first project of what we tried before we kind of hit on the thing that worked. And the very first project, or the very first prototype was, I called baseball cards, because it's lots of numbers and lots of stats. And so I, as a designer, had kind of gotten the research evidence from the research team that I was collaborating with, which is a lot of numbers from medical journal articles. And so the first one that I put together was this, just really trying to translate that information directly onto these cards. And then we had doctors and patients who were having discussions about their diabetes medication sort of use these cards. And what we found is that patients really liked these things, which is almost always true because patients get almost nothing in most clinical visits. And so they get really excited to kind of get any piece of information, but they couldn't use it. So went back to the drawing board and I said, well, maybe the problem is that there's not enough context. And so with the second version, I tried these narrative prototypes, which is essentially that same information now translated into longer sentences. We tried this again. The understanding of it was a little bit higher, but it was an awful lot of text to read in the middle of a visit, created kind of an awkward situation that way. And patients still weren't able to sort of do anything with it. And it was around this point that we began to kind of hone in on the idea that what we were looking to see happen was patients to ask a question or make a statement, that would be our way of knowing that they could actually begin to use these cards. And so the third version on the left-hand side you can see is literally the second version, the narrative cards cut up. And then we arranged the categories on the left and the medications on the top. And then on the right-hand side is a only slightly more sophisticated version of that, which we took out into the field. And the form factor didn't really make sense, but we asked patients to order the topics on the left-hand side, and then we built out the board kind of from there. And the ordering of the topics we found was the way in. Almost immediately, patients began to sort of say, oh, this is something that I'm really interested in, or I didn't know this, or ask a question to the doctor, would this potentially be the right medication for me? So we took that idea, and we went back and we made our own kind of the new idea for the cards, which we call sort of issue cards. And so now instead of the cards being about the medications, they're about the different issues that are relevant to patients. And this became kind of an on-ramp, a way for patients to be able to say, this is something that's really important to me. And once we, as the designer, I kind of led the development process. And at a certain point when we'd reached confidence that we could successfully make these kind of conversations happen more often than not, then kind of threw it over to the evaluation team that I worked with within this larger team. And they ran a randomized clinical controlled trial to understand what the effect of the intervention was. And to give you some little sense of what kind of came from that, so in addition to having all the patients fill out surveys, we also videotaped all of or as many of these visits as we possibly could. And the clinical trial found that the intervention group found the tool helpful. They saw it as something that had value to them. It did improve their knowledge, and it gave them they perceived that they had more involvement in making decisions. But at 6-month follow-up, both groups had near perfect medication use with better adherence actually in the usual group, and no significant impact on their A1C levels. And this particular study, the first one was done at Mayo. Mayo Clinic is a unique population of people, tend to be better educated, much more access. And so it's not totally surprising that the adherence didn't necessarily have an impact here. But what this, for me as a designer, began to kind of reveal is what are the things that you can measure and what are the things you can see? And what's the ongoing relationship and dialogue that you want to be having about those things? And so from this first project, what we've since done is we've developed a number of different decision tools that try and tackle some of these particular issues. This is one for chest pain in the emergency department. So people may come into the emergency department with chest pain. Tests show that they're not having a heart attack and don't need to be admitted into the hospital. And so the question becomes, is there allow them to participate in, do they want to stay in the emergency department to receive more testing, or would they like to go home and potentially be able to have a follow-up visit with their primary care doctor or cardiologist after that? This is a decision tool that I've been working on recently for head trauma in the emergency department. So the idea of being able to talk to people about whether or not they really need to get a CT for a concussion if they're, again, not going to be admitted into the hospital. They don't have sort of an obvious reason to have that happen. This decision tool revealed a really interesting fact to me that maybe some of you don't know, which is that you cannot see concussion on imaging. Concussion is just the name we give for not a brain bleed. And so it's been really interesting to be in the emergency department and trying to talk to people and begin to share some of this information. And they oftentimes follow up with, well, just to be sure, you should probably give me the CT. And we say, well, we actually aren't going to be able to see anything on the CT. And it brings up discussions about radiation and impact and what can be seen and what can't be seen, and creates really interesting dialogues between clinicians and patients that are revealing some of the places of complexity and uncertainty that are at the root of medicine. This was a decision tool we created for smoking cessation around surgery. So there's actually a lot of really interesting evidence that suggests if you are a smoker, even if you just quit for a week before and 2 weeks after your surgery, it greatly improves your wound healing. And so this was one of the hardest ones I ever worked on to try and foster a conversation, because clinicians were so reluctant to engage in any kind of a conversation that acknowledged or they perceived might give approval for people to keep smoking on some level. And patients were so sick and tired of being lectured by clinicians that they didn't want to kind of engage in this at all. But it's interesting to think about what are the opportunities where we can help people understand what we do know from medical evidence to inform the decision making that they may make without necessarily judging or requiring that they fall into one camp or the other. And so, again, we've done around 20 of these decision tools, and so a few, last year, there was actually a summary from all of those. What are the things that we can begin to sort of say or know about these tools? And one is that the age that we've been working in is around 40 to 92, so a big span there with the average age around 65. We've used them in primary care, emergency department, hospital, specialty care. The decision tools add approximately 3 minutes to the consultation. 58% of fidelity without training, which means that a clinician can watch a video, kind of like you saw before, and pick up the tool and start to use it. And 58% of them can use it pretty well without any more training than that. The effects on shared decision-making are similar in vulnerable populations. Like I said, we started out testing many of these things at Mayo Clinic, which is a unique population. We've really made an effort to go into other places and found that shared decision-making is just as effective in those places as well. And that really there's variable effect on clinical outcomes and cost, that's not necessarily, for us at least, where the primary motivation for doing a lot of this work is. But we also haven't been able to show that that's a reason to sort of pursue or kind of do a lot of this work. And so here, just to give you a little bit of a visual picture, this is for usual care. You know, about half the patients suggest accurate knowledge. Percentage can kind of estimate risk correctly. And then when we talk about the intervention, this is kind of the level of increase that we're showing. So again, it starts to give us this collaboration for me, especially as a designer with a group that does evaluation and research, is interesting because it gives me information that before I didn't necessarily have. And gives me places to think about how might we, are these things that we want to impact more? And if we do want to impact them more, how might we begin to potentially think about doing that? And the other piece that I think gets a little bit more at this idea of a long-term collaboration. So this is a group of people that I've been working with for about 12 years now. And I think one of the pieces of that has been that it's allowed us to really evolve our thinking on what the mission of shared decision-making is, or what the mission of our group is, and what sort of change we're trying to affect in the world. And and thinking a lot more thoughtfully about the models that we might put out there. And this is one that we've been thinking a lot with in regards to shared decision making, which is moving away even from just the idea of dialogue and thinking about what's the situation that demands action and what's the action that the situation demands. And recognizing that patients don't experience their diagnosis in a very black or white or kind of linear way. That how they experience it is they may be a person with diabetes who's beginning to experience low blood sugar levels while they're reading to their kids at night. And so what do they do in that situation? That's really what healthcare needs to be able to kind of help them navigate and help them kind of work through. And this type of work has begun to lead us to thinking about how do we design tools and programs, and what are the ways that we can help people speak to what matters to them, the way that we can help create and maintain relationships where that's possible, places where we recognize that physicians and patients may have different agendas, and how do we help them navigate and resolve those in a way that best fits this moment in time for this person. Developing the environments for problem finding and resolution, and have begun to think about the idea of conversation as a place where physicians and patients are testing out options in the form of hypotheses that they talk through to see what might best be the right fit for this particular person. And so the overall idea here, I think, is to begin to suggest ways that patients and clinicians can kind of collaborate and begin to come together. You can find out more of our decision tools. We make them all freely available online at Shared Decision Making Resource Center. And you can find out more about the other ways that we're trying to kind of address and tackle this problem at patientrevolution.org. Thank you.